Hello and good afternoon. Thank you all in advance for choosing to spend the next hour talking about a subject that I care pretty deeply about, namely the unique nicotine use patterns of and the need for tailored cessation treatment for Latine populations in the United States. My name is Jim Pavlik, and I'm the Senior Program and Policy Analyst for the Behavioral Health and Wellness Program within the Department of Psychiatry at the University of Colorado Anschutz Medical Campus. I've been in this role since 2013. I've also been a nationally certified tobacco treatment specialist since 2018. One thing I should make clear from the very start is that I do not identify as Hispanic, Latino, Latinx, or Latine, a term I will define in a minute if you haven't heard it already. I am what the US Census Bureau would identify as non-Hispanic white. So I will not be approaching this presentation from the vantage point of lived or living experience. However, I do have an undergraduate degree in Spanish and another in international studies with a global emphasis on Latin America. I also have a master's degree in international relations with a focus on Latin America. I lived in and studied briefly in Mexico. I used to work in neighborhood empowerment in a predominantly Spanish-speaking zip code with Spanish-speaking families. I have spent some time as a translator and interpreter, and when I was a caseworker at a community behavioral health organization in Arizona before I accepted my position at the university, my caseload was predominantly Spanish-speaking families. I also, to the best of my ability, relied as resources for this presentation on papers, photographs, and other materials created by Latine individuals. So I will not come to this presentation as a person who has lived experiences as Latine. I do have lived experience as an Anglo person who has tried very hard to increase my cultural competency and cultural humility in general, and in the specific case of expanding both to Latine communities. This is an ongoing journey, and if you happen to identify as Latino or Latine, Hispanic, I will happily accept constructive criticism regarding anything that I could say or do better. Aside from that, I do not have any other disclosures to make. So today's objectives are pretty straightforward. The terms Hispanic and Latino are more complex than they may seem at first. So I want to start with defining these groups and highlighting some pretty severe injustices that come from using a blanket term to describe an incredibly diverse group of people. In fact, I will discuss the inadequacies of these terms at the outset, and I will be highlighting their shortcomings throughout the presentation. From there, I will spend some time talking about the differences in tobacco use patterns, as well as health disparities that are downstream or run alongside these differences in use. And finally, I want to briefly discuss some considerations that we should keep in mind as you tailor care for individuals who identify as Latine or one of its companion groups or as one of its diverse subgroups. So let's get some terminology out of the way. In general, the two terms you're most likely to hear are Hispanic and Latino. And before I go into these two terms, I want to briefly give thanks to Terry Blass, a Latine artist who creates fantastic comics, two of which I've included some art from for this presentation. The one you see here is linked at the end of the presentation, and it's called You Say Latino, a mini comic. The other, also linked at the end of the presentation, appears in just two more slides, and it's on the term Latine that you keep hearing me use. Mr. Blass graciously allowed me to use his work for this presentation, and while I am summarizing the main points of each here, I do encourage you to follow the links and read them in their entirety and share them widely. In short, Hispanic and Latino are not interchangeable, although they are frequently used and heard as if they were. The term Latino refers to individuals from Latin America. Now, that term itself is a little confusing as the history around its creation and early use has not been entirely consistent. In general, we think of Latin America as Western Hemisphere territories that bear the mark of colonization, specifically from Portuguese, French, and Spanish conquerors and colonists. That is, Europeans who speak languages that descend from Latin. By contrast, the term Hispanic describes someone who natively speaks Spanish, and you can see Mr. Blass's two illustrative examples, and these are the ones to keep in mind when you think about the distinction. Someone from Brazil is Latino, but not Hispanic, and someone from Spain is Hispanic, but not Latino. Now, the reason these terms are so readily conflated is simple. Individuals from Spain are basically the only Hispanic people who are not Latino. There are 20 countries, Puerto Rico, and some states within the United States that use Spanish as an official language, and all but Spain are in what we would call Latin America. And while there are a few countries in Latin America that do not speak Spanish, they speak French, English, or Portuguese. All but Brazil are very small and consequently have very small diasporas in the United States, which is not to say those individuals are unimportant, but it is to say that in America, when we refer to Latinos in the United States, the very, very, very vast majority are also Hispanic, and the very, very vast majority of Hispanics in this country are also not from Spain. So they are Latinos. To illustrate this, here is a list of territories in what we call Latin America. You will note that I have included Puerto Rico here. Puerto Rico is not a sovereign country in its own right, but I think the people there are rightfully characterized as both Hispanic and Latino. For one thing, when surveyed, just about 99% of the archipelago self-identify as Hispanic, and it was colonized by Spain and under its control for nearly 300 years before America took control of it at the end of the 19th century. And as the second largest group of Hispanic and or Latino individuals in the country, it's weird for me that Puerto Rico is often left off of lists like this. So these purple ones here, there we go, or sorry, these are the ones that we consider Latin America, and then these purple ones here, there we go. These purple ones are the top 5 places of origin of Latino or Hispanic individuals, and you can see that all of them are both Hispanic and Latino. In fact, were we to include the top 10 Hispanic or Latino groups, 8 of them would be both. One would be Latino but not Hispanic, Brazilians at number 6, and one would be Hispanic but not Latino, Spanish at number 9. Collectively, these 5 represent more than 80% of the Hispanic population and the Latino population in the United States. In fact, 62% of Hispanic and Latino individuals claim Mexico alone as their place of heritage. To be clear, I am not arguing that this should mean that it is right to conflate these terms. I merely understand why it happens. In fact, in many research papers looking at this population, the authors don't refer to Latino or Hispanic, but use the connected phrase Hispanic/Latino to call attention to the fact that they are referring to this group that lies at the intersection of the Venn diagram. So now let's turn our attention to another term that you may have heard regarding this population, which is Latinx. So Latinx replaces Latino. For those who are not aware, Spanish is what's called a gendered language. All nouns in Spanish are masculine or feminine. This is signaled at the very least with a change of the words the or a that precede a noun. These are called the definite and indefinite articles, respectively. So if a word is masculine, the word the is el, and the words a or an is un. So the sun is el sol. A feminine noun uses la and una for these articles. The moon is la luna. In addition to changing the articles in many nouns, the final vowels change between an O for masculine words and an A for feminine versions of the same word. So someone from Mexico is either un mexicano if they are a man, or una mexicana if they are a woman. So this obviously presents difficulties for an individual who does not identify as a man or a woman. Enter the word Latinx. Here, the final vowel is simply replaced by America's and Spain's favorite placeholder character, a nice gender-neutral X. However, in Spanish, this is unpronounceable. The letter X across Latin America has 3 unique pronunciations, but none of them would work in this location in the word, and you can't pluralize it. Enter Latine. Latine is great because it doesn't use the O or the A at the end of the word, and it is readily usable fluidly within current Spanish grammatical structures. I learned this word from this comic that you're seeing, but I've since seen it elsewhere, including in other cultural competency trainings and manuals, even one in an online magazine by Spanish speakers for Spanish-speaking senior executives. I don't know if it will pick up steam, and I know there's some controversy around it, but there is an active community trying to make it happen. I know this term is controversial for some members of the Hispanic and Latino community, and maybe you're one such person yourself. And it's worth noticing this controversy and noting it. I have been studying and immersed in Hispanic Latino cultures for a long time, and as a person with a lot of respect for that community, I have longed for a consensus on the best collective noun. It doesn't exist. All the terms mentioned so far have their supporters and their detractors. As always, it's best to refer to an individual by the group noun they use to describe themselves, and you may find many other terms that I haven't brought up. Chicano, for example, is one. For many, they refer to their specific nation of origin, Salvadoreño or Salvadoran American for someone from El Salvador, etc. For the record, for the remainder of this presentation, I'll be using the term Latine. And when I do, I am referring to Spanish-speaking Latine, not to conflate the terms, but simply for simplicity's sake. Relatedly, since I am talking specifically about Latine in the context of America, I will mostly be referring to Anglo rather than non-Hispanic white as the main comparator group. And I think as a term that better captures both their geographic origins as well as their language group. Although, for obvious reasons, this term isn't perfect either. It also has the benefit of being shorter than non-Hispanic white. So let's turn our attention now to the tobacco use progression from pre-initiation through initiation to use and ideally to cessation. Before an individual experiments with tobacco, certain factors make one susceptible to future use. Obviously, age is a factor, with very young children not particularly susceptible. As one moves through adolescence, susceptibility rises. And then as one enters young adulthood, if one has made it that far without experimentation, susceptibility falls again. Race and ethnicity matter specifically for minoritized groups, which generally have less access to things like education, high-paying jobs, health insurance, and stable, high-quality housing, and suffer from various types of prejudice and bias, all of which increases stress, limits access to healthcare, and generally lowers health status. And all of these things make tobacco use more likely. I do want to add a quick note in regard to genetics, even though I think that topic generally falls outside the scope of this presentation. There is very little work looking at genetic links to tobacco use, dependence, and cessation. The few that we have seem to have located a genetic vulnerability to those things within Western European populations, which is to say that European genetic lineages are more apt to experiment and use tobacco and more likely to experience worse withdrawal and cravings. It's worth noting that Latinas are not only diverse culturally, historically, and socially, but also biologically. The contemporary Latina population are variable combinations of Spaniard, Black, and Indigenous peoples who themselves are also all biologically diverse. For example, Dominicans and Puerto Ricans in large-scale genetic studies show the highest levels of African ancestry. Colombians show genetic lineages across the Andes and Caribbean. In Mexico and Ecuador show the highest levels of indigenous ancestry. And of course, there are going to be variations within countries, and it goes without saying, between individuals. So it is possible that much of the variations between territories of origin that we will discuss today have genetic rationales, but for now, this is largely unknown. To some degree, everyone is susceptible to the potential allure of tobacco, and in particular, those groups targeted by the tobacco industry, which includes young people. Something we know for a fact from memos released during the Master Settlement Agreement in the 90s and were witnessed to very recently in the Instagram and Twitter campaigns launched by Juul just a few handful of years ago. The tobacco companies have been marketing to Spanish-speaking individuals for a very long time. A quick web search will pull up several ads from the 40s, 50s, and 60s. However, the true scientific marketing push really took off in the 80s when this population was singled out as lucrative and underserved. Those are quotes from the tobacco industry, lucrative and underserved. Creating ads in Spanish was not for the tobacco companies just about communicating to Latinas, but a signal that their language and culture was acknowledged and accepted. This was a novel approach for American brands at the time. Moreover, the tobacco companies were the first to truly appreciate that across countries and within them, Spanish was characterized by different accents, different dialects, and different idioms. They recognized that both that a failure to understand that would mean alienating those who they were trying to persuade, and that completely doing it would instill greater trust. In fact, cultivating trust within the Latina community was a big part of their overall marketing strategy, and it didn't stop with the use of regionally appropriate Spanish. They also funded Latina social events, concerts, charitable funds, etc. The same strategy previously used to cultivate Black allegiance in the 50s and 60s. The tobacco companies discovered through surveys, focus groups, and other research methods that Latinas, more than their Anglo counterparts, are family-oriented, and that their Hispanic roots were a big part of their overall identity. As a result, they leveraged these features in their ads. Again, this idea of leveraging strengths and converting them into susceptibility to trying tobacco was not new to the Latina strategy. In the past, they had, for example, highlighted frugality as a virtue while sending out coupons for cigarettes. to Black housewives, whom they called frugal, a strategy repeated with Latina women who were also found to be more cost conscious than Americans broadly. They highlighted the Americanness, quote, Americanness of their brands and encouraged their consumers to be seen smoking their brands so as to appear more American. And they discovered that Latine preferred local groceries and small shops in their local neighborhoods. As a result, getting cigarettes into these local shops became a priority, and shopkeepers were incentivized to carry cigarettes. As a result of this strategies, Latinas now live today in neighborhoods with a higher density of retail cigarette vendors and live generally closer to a point of sale than Anglos do. So the papers I'm citing on susceptibility note that Latina have higher susceptibility than their non-Latina counterparts, and that susceptibility has been rising over the past 10 years, possibly related to the rise in popularity of ENDS products, electronic nicotine delivery systems products like Juul. 2014 was the year that ENDS surpassed conventional cigarettes as the primary way that teens were consuming nicotine. Those same papers also note that Latina's consistently higher susceptibility has not translated into higher use, at least not yet. In the National Youth Tobacco Survey, from which these notes were abstracted, the comparator groups are non-Hispanic American, Indian, Alaskan Native, Asian, Black, and Anglo. Among those group, Latina high schoolers have the highest rates of initiation, the third highest rates of cigarette smoking, and the second highest rates of the use of electronic nicotine delivery systems and pouches. And Latina middle schoolers have the second highest rates of cigarette and cigar smoking, and the highest rates of ENDS use. And just to be clear, ENDS, when I use it on the slides here, means electronic nicotine delivery systems. So moving on to adulthood. Whenever there is a presentation on a specific population, the question always emerges, what are the disparities? And from a 10,000-foot view, the Latina population looks pretty good, all things considered, at least in regard to their use of tobacco, comparatively speaking. So here on this slide are the prevalence rates for adult tobacco users of varying products. The general population, which includes everyone, is the orange bar. The Anglo population is the brown bar, and the Latina population is the gold one. And across all products, you can see that adult Latinas are using at lower rates than their Anglo counterparts and the general population. But things may be changing. Now, whether or not they are changing will be determined in the future, and making guesses now is speculation. But I'd like to show a few more graphs that, in my opinion, suggest at least that things may be changing for the worse. Here is a chart of high school prevalence rates. Same three demographic groups, same categories, plus the addition of nicotine pouches, which don't yet show up on the adult survey that I just showed. Here you can see that Latinas are still using fewer tobacco products than Anglos, but the gap isn't nearly as large. And Latina are even with the general population in some products, and with cigarettes now smoke more than the general population. Now, keeping this chart in mind as I advance the slide, here is the middle school graph. Same demographics, same tobacco products. And as you can see, among every product except conventional smokeless tobacco, middle school aged Latina have surpassed both Anglo and general populations in tobacco use. Now, these three slides are not the result of a longitudinal study. We do know that historically Latina have earlier initiations than their counterparts, and early experimentation that progresses to cessation in high school remains a possibility, a feature that the authors on susceptibility noted was true at the time. But it is also a possibility that younger cohorts are simply more interested in transitioning from susceptibility to use. So I'm not saying that things are getting worse, but it is something we have more evidence of, which I will share in just a bit, and something to keep our eyes on. Now I want to dig a bit deeper past the term Latina to see if we can get a clearer picture of what's happening with this population in regard to their tobacco use. About half of Latina smokers are classified as light and or intermittent. Light means they smoke fewer than 10 cigarettes each day, and intermittent means they don't smoke every day. This should be an indicator of lower dependence and therefore more successful quit attempts, even if it should also correlate with fewer quit attempts. In general, we see that the heaviest smoking populations often have the highest desires to quit. And we'll see in a moment if any of that is true. But before looking at cessation and health outcomes, I want to say that sometimes we prioritize disparities over other aspects of health. Preventable harms should be prevented, whether it happens disproportionately or not. The fact is that tobacco use is the #1 killer in every population that engages in it all over the world. And while Latine's lower use and lower intensity and lower frequency of use may be informative to public health communications specialists from a clinical perspective, our job is to help the people who use tobacco. And Latinas that use tobacco are a specific population of interest specifically because the broader use rates are lower than the general population. In a community that seems to have specific protections against use or dependence, what are the special circumstances that drew this or that individual to use tobacco, and why are they seeking our help? And what do we need to know to help them? The fact is that Latinas that use tobacco have different cultural and social pressures than their Anglo, Black, or Asian counterparts. And as a result of those social cultural differences, different treatment approaches may be warranted. A few slides ago, I said that from the 10,000-foot view, Latine look pretty good, at least in terms of their use rates. So let's bring the plane down a bit closer and see if we can see through the halo that's observed from a distance. One thing observed here are significant differences between Latine from different territories of origin. Here are the World Health Organization's 2020 estimates for smoking rates in Latin American countries, the US, and Spain. I put in boxes the prevalence rates for Spain, the US, and the top 4 nations of origin. Puerto Rico is not on this list because the World Health Organization doesn't separate Puerto Rico out from the rest of the United States. But if it were on the list, it would be close to the Dominican Republic at about 10%. One thing to note here is that aside from Spain, the US has among the higher prevalence rates on the chart. One could infer from this that the lower rate of use among Latinas is driven by lower use in their heritage countries. However, we have some evidence that low rates in sending states does not correlate with low rates among their various diasporas. To highlight this and to also illuminate a severe limitation of a catch-all term like Latine to a group that has this much diversity, let's look at the results of the only study, to my knowledge, that has looked at smoking rates within different Latina groups in the United States. So this data is going to be from 2014. And the first thing that we should appreciate is that 10 years ago, the smoking prevalence rate in the country was 16.8%, but the rate among Latinas was only 11.2%. And that seems pretty good. This is the 10,000-foot view that I keep talking about. The gap between these two populations is similar today. But once we dig past the top line category, this is what we see. Although Puerto Rico has one of the lowest prevalence rates in the country, it has a rate lower than 48 out of 50 states. Puerto Ricans in the mainland US have one of the highest rates of any population. Similarly, Cuba has a relatively low smoking rate compared to the United States, but Cubans in the US have the second highest rate of all Latina groups. And while most Central American states on the previous graph were all very low, Central American men are higher than the Latina average. I mentioned earlier that Latina reporting Mexico as their nation of origin represents 62% of all Latina in the United States. And it seems clear to me that it is their relatively low smoking rate and their large representation that masks concerns about use rates, at least in some populations. One thing that is broadly true is that, in general, men use more tobacco than women. In the United States, it's about a 4 to 6 point gap depending on the survey you use. That means that almost everywhere in the United States, if you know the prevalence rate for the general population, simply add and subtract 2 to 3 points from it, and you will have a good estimate of the prevalence rate among men and women respectively in that area. Now, we saw in the last chart, Latina men smoke significantly more than Latina women. This we would expect. However, this is something that also varies by territory of origin. You can see from this chart that the United States has among the smallest gaps compared to the other Latin American states and Spain. And in many countries, that gap is enormous. like Honduras at the top with a 20-point gap between men and women. In fact, in half of Latin American states, the gap is about twice as large as it is in the United States more broadly. What this means is that if you take Honduras as an example, the prevalence rate in Honduras is low by US standards. About 12.7% of the population smokes. But that means that the prevalence rate among men is 23.5%, higher than the United States general population. All those previous slides form the foundation for a particular argument, which is that we can't really tailor care for Latines, which is something that tobacco companies have understood for at least 40 years. Just as they tailor their ads for regional populations, we have to tailor our care for the unique populations that reside in our area and for the individual that sits in front of us. What we've learned so far, I think, is that age matters a great deal. Territory of origin matters, acculturation matters with those living in the United States smoking more than their peers in their origin states, and sex matters with men outpacing women, and within some cultures by quite a lot. The pictures on this slide are the top Latine groups in each state. The map on the left shows the largest group in each state, and you can see most of the map is light blue, which denotes areas where Mexican is the #1 group. Up in the Northeast, you see a big patch of dark blue, which are areas where Puerto Ricans are the top group. Down in Maryland, it's pink for Salvadorans. Florida is purple for Cubans. And we see wee little Rhode Island is orange for Dominicans. On the right is the second largest group in each state. And here the map is a lot more colorful. Here you can see that quite a few of the light blue states have turned dark blue, which is to say that Mexicans are the biggest group in most states and Puerto Ricans are the second largest. And indeed, this is true for the nation as a whole as well. And about half the states that had Puerto Ricans in the top spot have Mexicans in the second. The Northeast has Dominicans in #2. Salvadorans, who were #1 in Maryland, are the second biggest group next door in Virginia. But let's talk about this corridor from the Southwest to the Northwest. Across the Southwest, you see Hispanic showing up. And up in Montana and Oregon, you see that gold color, which indicates Spanish. And connecting those two regions is a pink color, which is Spaniard. These are all interesting, as in general, most people don't think of a lot of Spanish immigration to the United States, but these are all parts of our country that were originally colonized by Spain and were, in fact, part of Mexico before the Gadsden Purchase of 1845 and the Treaty of Guadalupe in 1848, which is to say that these are folks identifying as either directly Spanish or claiming a non-nationalist Hispanic identity that is distinct from a Mexican identity, which is to say that they are from where they are, and that area hasn't been Mexico for a really long time. Now, although every state will be different, it's worth it, I think, to look at what the beginning of such state-specific explorations may reveal. Pictured on this slide are two graphs I was given permission to use by the graph's author, Arnold Levinson, from the Community Epidemiology and Program Evaluation Group, CPEG. Dr. Levinson is leading a group here in Colorado looking at the role of intersectional inequities in driving health disparities. Funding for this work was provided by Colorado's Amendment 35 Tobacco Education Prevention and Cessation Grant Program. Any views that I express here do not necessarily reflect any official policies of, nor does the mention of them imply endorsement by the Colorado Department of Public Health and Environment. On the left, you can see fairly large discrepancies in tobacco use between sex and by language, with English-speaking Latine men smoking at nearly 4 times the rate of Spanish-speaking Latine women. On the right, you can see large disparities between those who identify as, in our case, Hispanic men, Hispanic only, compared to 2 different groups, Anglo men, the lowest line here, and Hispanic men with at least one other source of inequity. So here in Colorado, the most common inequity among Hispanic men was being an enrollee in our state Medicaid program. And as you can see on this chart, not only are there key differences between these groups, but the gap between Anglo men and Hispanic men has actually widened, as there has been little progress in smoking prevalence rates in the past 18 years among Hispanic men, while smoking among Anglo men has dropped over 1/3 over the same period. Knowing that these disparities exist is the first step to hopefully finding a way to close them. One thing I really like to do is tell complicated stories. So I would like to complicate this idea that I have been promoting for the last several slides, that there are significant differences in use by territory, that care has to be tailored accordingly. Back in the 80s, the tobacco companies determined that while there were pretty big differences between Latino groups from different areas, they also learned that Spanish and a Hispanic identity was a unifying feature. There is some evidence that this unifying Hispanic culture is growing even as it changes. Among participants in a study of young Latinas, the relationship between these individuals and a Latina identity were complicated. They felt simultaneously disconnected from the Latina identity they were presented, while also feeling tied to other individuals within the Latina community as they understood it. And their common bonds were cultural bonds like language, food, and music. While they recognized typical features of their culture, like machismo, they also didn't feel obliged to adhere to those particular norms. Which is to say that there is some evidence that the differences that I've spent so much time highlighting may be flattening out with the younger generation. There were, for example, no meaningful differences noted between Latina groups on their perception of or experiences with electronic nicotine delivery systems. And this may also be why we see middle and high schoolers close the gap with their Anglo counterparts, specifically around those products. Just something to be mindful of if you're working with younger cohorts. When working with a patient on a cessation attempt, it's important to understand both the reasons they used tobacco in the first place, as well as their motivations to quit. So let's look at the first one. In a study including over 1,000 participants, which included some focus groups, the items on this slide were the most cited reasons that Latinas gave for smoking. The top category was mood management, which included both stress management and coping with mental illness. This was followed by an acknowledgement of their dependence in two different ways. The first way was in acknowledging not the dependence directly, but rather their weakness, quote unquote, weakness in the face of dependence. That is, they prioritized their lack of self-control or willpower. Then various factors associated with dependence emerged. Now, this included how the dependence was activated by the presence of environmental cues like the presence of alcohol, coffee, or just having cigarettes around. And finally, they mentioned using nicotine to deal with uncomfortable work situations, family situations, or other social issues. And this brings us to cessation. I mentioned earlier in this presentation, and again recently, that about half of Latina smokers are considered light and or intermittent smokers. Now, we would hypothesize that this would mean a lowered interest in quitting, but greater success in doing so. Interestingly, neither of these things are true. In fact, the interest in quitting is almost exactly the same as it is in their Anglo counterparts. Just about 70% of both Anglo and Latina who currently use report wanting to quit within the next 12 months. In fact, that 70% figure, plus or minus a few points, is pretty consistent across most groups. And as I mentioned, the heavier the use in a specific population, the higher the interest. This strikes many people as counterintuitive, since heavier use indicates heavier dependence, and therefore they reason lower interest in quitting. But in fact, it's the opposite. More heavily dependent smokers are often aware of their dependence and desire to make changes that they find difficult to make. Moreover, they are more aware of the financial and health costs of use. In any case, we do see fewer quit attempts made each year among Latinas than among Anglos. It's only about 53.3% among Latinas. And their success is about a point higher, but not to a statistically significant degree. Although other studies have shown that Latinas have lower success. In any case, whether it's a few points up or a few points down seems to be more a matter of statistical noise. Latinas that switch from cigarettes to some other tobacco products are most likely to switch in order to electronic products, smokeless products, and then cigars or pipes. And actually, this order is not unique to Latinas, although the percentage that make each of these switches does vary between populations. Generally speaking, folks are simply switching from the most popular products, in this case cigarettes, to the next and the next and the next most popular product. So I would suspect in the next few years, seeing oral nicotine pouches like Zen show up on these surveys as a popular choice for so-called harm reduction. There are some other differences in cessation to note. Latinas are more likely to cite family as their strongest driver. The majority report quitting without medical aids. And of those who utilized support, pharmaceutical aids in combination with psychosocial treatment was the highest at 19.2%, followed by pharmaceutical aids alone at 16.6%. However, these numbers are 2/3 the use among Anglos, which are 34.3% for combination treatment and 32.6% for pharmaceuticals alone among Anglos. And they're less likely to receive quit counseling from healthcare providers. Also want to note that individuals in the qualitative study mentioned earlier also cited the helpfulness of the tailored materials they received. And I'll mention that again in a minute. But the tailored materials they were talking about is the one pictured here, Libre de Cigarrillo, por mi familia y por mí. This is an entire program with both participant and group leader materials, and I have it linked for you at the end of the presentation. So we had mentioned earlier that there were fewer quit attempts made by Latine compared to Anglo and other groups. There are a lot of potential reasons for this, and I put a few of them on this slide. Latine are less likely to be asked their smoking status. Latine are less likely to receive advice to quit compared to Anglo or Black smokers, and those rates are pretty distinct. I have them listed there on the slide. Latine adolescents are also less likely to be screened for or given the advice to avoid vaping. They're less likely to be offered smoking cessation programs. They're less likely to be screened for some cancers, and they're more than twice as likely to be uninsured. Now, we may not think much of tobacco use if it weren't for the fact that tobacco use kills so many people. In fact, here's a list of the top 10 killers in the United States, and tobacco use either directly causes or is associated with all of them. And while these are the top 10 killers in the US's general population, if we switch the orders around a little bit, these are the top 10 killers of Latine too, particularly heart disease and cancer. One thing to note here is that because the Latine population in general skews younger, they tend to have a disproportionate share of cancers that strike younger people as well. One would suspect that due to their lower, lighter, and less frequent use, that there would be fewer tobacco-related diseases, and that does in fact seem to be the case. Latinos, for example, are less likely to have coronary heart disease. Their risk of certain tobacco-caused cancers is lower, which we'll see on the next slide. And in many cases where Latinos do have higher risks of certain tobacco-caused diseases, their risks in particular are likely driven by other causes. For example, diabetes may be driven more by Latinos' higher risk of obesity, and higher rates of some cancers may be driven by viral infections. Tobacco causes cancers at 12 sites in the body, and those are listed here. You will see that 2 of these cancers say no data. I don't mean to suggest that no one anywhere has this data, but the source I'm citing here didn't list these cancers, and they didn't mention why they didn't mention them. And as cancer is not a particular area of specialty, I didn't feel comfortable looking to insert data from other studies that may be using different terminology or methodologies. As you can see, as I just said, many of these tobacco-caused cancers have lower incidence and lower mortality figures for Latine compared to Anglos. And as I already mentioned, many that are higher may be from non-tobacco origins. Many Latines, especially foreign-born Latines, have higher risks of cancers caused by viruses. However, although they may have lower rates from tobacco, Latine patients should still be informed of their greater risk of these cancers so that they can limit aggregating or multiplying their risks. As with smoking rates, we need to remember that Latine is a blanket term that obscures more than it reveals when it comes to both tobacco use and its health outcomes. When we say Latine or Latino or Latinx or Hispanic/Latino, we have to remember we are talking about a group of people, some of whom can trace their ancestry in this country back 400 years. And there are as well a substantial number that immigrated here in the post-World War II era, others that arrived here during the democratic collapses in Central and South America in the 80s, more still who arrived during the economic high times of the mid to late 90s, and others who arrived quite literally in the last few years, months, or even weeks. We are talking about Mexicans, Salvadorans, Venezuelans, Cubans, Dominicans, Puerto Ricans, and use varies between all of these groups, and of course also between men and women. And as use varies, outcomes vary. Latinos are far more likely to develop type 2 diabetes. In fact, it is projected that half will be diagnosed with it in their lifetime. In 2014, the Surgeon General's office determined that diabetes was caused by smoking. However, even as I was preparing for this presentation, many of the websites I found offering advice to Latinos on how they might reduce their risk for developing diabetes, none that I found mentioned reducing or quitting smoking. Here are some other examples. Mexicans have a greater risk of developing type 2 diabetes over other Latina groups, and this might be linked to a specific genetic difference that is higher in individuals from Mexico. Death rates from colorectal and lung cancers are twice as high in Florida, in Cuban men as it is in Mexican men, and we know from a previous slide that Cuban men smoke a lot more than Mexican men do. Cancer mortality in Texas is 61% higher in US-born Latina men than in foreign-born. And liver cancer death rates were twice as high, again, in California for US-born Mexican men as opposed to foreign-born. Finally, I want to spend just a few minutes talking about some of the things that we can do to improve care for Latina patients. First and foremost, I want to acknowledge that a lot of Latina health outcomes are poorer simply because of systemic causes, and many of those systemic causes are outside our day-to-day control. However, we all have some, even if limited, voice within our own systems of care. First and foremost, the easiest change we can make is having uniform screening and referral protocols in place. Everyone gets screened for tobacco use. Every positive screen results in referral to care utilizing an opt-out rather than an opt-in approach. And we want to ensure that, that the uniformity of these screenings and referral protocols are verified through some review process, either a randomized chart audit or even better, a tobacco use registry. And of course, we can go well beyond that. MD Anderson has one of the best tobacco treatment specialist operations in the country, which can serve as a model for other hospital systems. I think the most obvious barrier that most people think of when they think of serving the Latino population is the language barrier. And there are a lot of solutions to that one. We can have all materials printed in English and Spanish. We can have in-person or online or telemedicine interpreters available. But the best solution is to hire Latina MDs, nurses, PAs, and MAs. Representation matters. And using promotores. For those who have not heard that term before, promotores are Spanish-speaking lay health workers who live and work in the communities they serve. Traditionally, these have been more women-led efforts, and if you search for the term, use the traditional word promotoras with an A. I'm using the more inclusive E, as I have been with Latina. We need to understand that Latinas face different marketing campaigns that appeal to their unique values and life experiences. These messages are finely tuned with millions of dollars of market research. To know what your Latina patients are hearing, seeing, and reading, spend some time looking at, watching, and reading their media. Obviously, if you are Latina yourself, you may already have a beat on this. But if not, head into the vape shops in your Latina-heavy neighborhoods. Grab some magazines off the shelves. If you read Spanish, scroll through TikTok, get on Reddit, and see what's out there. Not only will this help you understand their ideas around tobacco, they will also give you clues as to the way you might frame your rebuttals and clinical advice. One consistent thing seen in Latina patients is their persistent underuse of cessation pharmacotherapy, and this may be tied to widespread misinformation about pharmacotherapy. So it's worth, one, making sure you are up to date on your knowledge of the FDA-approved medications for cessation, and two, discovering what your patients know or think they know about it, and three, gently and politely correcting any misunderstandings that you hear. One thing to keep in mind is that Latina have comparable prevalence rates despite all the systemic injustices and daily stresses they face. It is important, especially in regard to the higher degree of fatalism in this population, that we spend some time talking about their strengths, their resilience, their resourcefulness, the strength of their families, and if they're religious, their faith. Another thing to keep in mind is that both living as a minoritized person and tobacco use are associated with higher rates of mental illness, including depression. This is not the same as fatalism, but it does go hand in hand with it. Research suggests that both Black and Latina individuals are more likely to express a belief that the events of their life are things that happen to them, and there is little, if anything, they can do about it. This manifests as less engagement in chronic care regimens, as well as not following through with recommended screenings. So, in addition to highlighting strengths and resources, clinicians should seek to empower their clients, letting them know that nicotine dependence is a treatable condition and that they have the power and the tools they need to succeed. Interviewing several Latinas who successfully maintained their abstinence for 6 months found the following commonalities. First and foremost, focusing their thoughts on their health was reported as being helpful. For some, this means attempting to avoid negative outcomes like preventing a tobacco-caused disease. Indeed, for some, the dominant emotion here was fear of that outcome. For others, this same idea was caged more positively in terms of their health gains. Access to and the use of Latina-tailored materials. Perhaps related to countering fatalism, hearing success stories from other Latinas was an important component of their treatment and a noted feature of the tailored materials they received. Many cited family and friends as important resources, although this too was framed both positively and negatively. Positively in the sense that both were cited as sources of strength. Negatively in the sense that the nagging or pestering from their families was both a motivation to quit and a motivator to stay quit once they had succeeded in quitting. Never underestimate the power of a well-mannered nag. Pharmacotherapy was specifically mentioned. Again, knowing the misconceptions around pharmacotherapy that some Latinas have and their low use of these effective medicines, and knowing how well they respond to success stories, being sure to share success stories of other Latinas that used pharmacotherapy is a good way to combine these lessons learned. And finally, the Latinas in the study mentioned their faith and spiritual practice as sources of inspiration, motivation, and resilience. These are the links to the resources mentioned throughout the training. And these are the citations I used for the content. If anyone has specific questions about where this or that specific claim or fact came from, you can shoot me an email and I can just point you to the right reference so you don't have to fish through all 23 of them to find the ones you need, or I'm sorry, 24 of them. And the best email to reach me at is this one right here. This actually goes to our whole team here at BHWP, and the person who can answer you the quickest will be able to respond to you. Although if it's a question about this presentation, that person is almost certainly going to be me. So at this point, I will go ahead and open it up for questions. Says, Melissa says, are these cessation stats reflective of the Latinx communities? And it was so yes. All the cessation stats I gave were specific interviews or statistics from American Latino populations. Yeah, I just heard about that flavor ban passing as well, Melissa, and I think that is excellent news. And Susan, Susan's asked, what is the difference between the smoking category versus the cigarette category? I may have mislabeled a slide. Countries of origin. This one? Oh, exactly that. So those are, it's all combustible use in orange there, Susan, and then cigarettes specifically in the gold color. Any other questions? or comments, thoughts, feelings, pushback? So Angie has just put our evaluation link in the chat. I'm hoping everybody will take just 2 or 3 minutes of their time to answer those questions. We always appreciate your feedback. The link again is in the chat. And please hit it before you head on out. Thank you all so very much.